All right. Thank you, Dr. Miloslavsky. So we have one more talk before our break. And during the break, too, you can find some folks and ask additional questions if you have them. So I'm so pleased to introduce Dr. Camille Cotton. Dr. Cotton is the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases Programs in the Infectious Diseases Division at MGH and an Associate Professor of Medicine at Harvard Medical School. She served as the chair of the Infectious Disease Community of Practice of the American Society of Transplantation and the president of the Transplant Infectious Disease section of the Transplant Society. Her interests include cytomegalovirus, vaccines, donor-derived infections, zoonoses, travel, and tropical medicine in the transplant setting. So we're so pleased to have Dr. Cotton as one of our close collaborators in the vasculitis program, and we're excited to hear what she has to say.
Thanks a lot. It's really a pleasure to be with you all. There's nothing I love more than doing educational endeavors, and I think it's so great that they're doing this program so that you can learn a lot and empower yourself and then share your knowledge. So I'm going to talk about the risk of COVID-19 when immunosuppressed. I'm sure that the anxiety in the room may have gone up just a tad thinking about COVID-19, but the goal today is actually to talk about how to kind of slay this beast and decrease the overall risk of what has been a challenging past 3 years. We didn't say, but I'm actually on this Center for Disease Control Advisory Committee on Immunization Practice, so I've been involved in making COVID-19 vaccine decisions, and I've been the assigned champion of the immunocompromised host. I see various colleagues in the room who have messaged me, especially John Niles, who have messaged me and have really helped shape national policy on vaccines. So I'm appreciative of that and all my colleagues here today. So just to highlight, where are we now? Well, in Massachusetts, we have a lower case rate than before. We do still have an estimated close to 500 cases a day with a 5% rate of positivities. That's still pretty high, 450 people in ICUs. I'm sorry, 450 people hospitalized, 50 people in ICUs, and about 12 deaths per day. So for me, that's still far too high. The wastewater, probably many of you are familiar with wastewater. This is pretty cool. You know, we're looking at the amounts of COVID-19 in wastewater from both the North Shore and South Shore. And we've been able to really track outbreaks with the amount of COVID-19 in wastewater. And you can see that fortunately the numbers are really on the way down, which is great. There's still too much, but at least we're trending in the right direction. And if we look at the Massachusetts dashboard, and all of this information is available publicly, you can see that it's pretty even distribution as far as how many cases there are by age. This doesn't distill out like immunosuppression or not, but you can see still a good number of cases in populations that should be well vaccinated. In recent times, we've seen this XBB 1.5 really take over as far as the variant strain. From many of you may have gotten the monoclonal antibody Evusheld for protection. And unfortunately, in recent times, pretty much many of the strains that have been active since late last year have all been resistant to Evusheld that was given for prevention. So that's unfortunate. You know, this is how it is now. I'm sure that some other strain will soon take over. There's also more than just COVID-19 out there. I did want to highlight that this year we had a really early influenza peak. Luckily, the influenza numbers have really come down, which is great. It was pretty atypical to see such early influenza, but it's not just COVID-19 that we worry about. We also worry about influenza. And then, and you can get a high-dose influenza vaccine to protect yourself. And then we also worry about respiratory syncytial virus. And we also saw an atypical and early peak this fall with RSV. Interestingly, for RSV, there may be an adult vaccine that gets approved and may be recommended this year. So that will be something to keep your eye on. So there could be, of all of these respiratory viruses, it's kind of a great time where we are having effective vaccines that can really decrease not always the risk of infection, but certainly the risk of severe disease. We have to think about how to appropriately use these in populations who are on drugs that suppress the immune system. So let's just walk through some of the topics on COVID-19. So if I test positive for COVID-19, what are my next steps? So we know that of people who get COVID-19, people at higher risk for complications include those of older age, those with multiple medical conditions, those who are unvaccinated or who don't have significant efficacy or effectiveness of the vaccine, and then those that are on more potent immune suppression. So this is a continuum. I will say that this was developed earlier in the pandemic, and overall, we are seeing much, much better outcomes in recent times. So luckily, the higher risk isn't as high as it had been. So what do you do if you're sick? So if you are at high risk and you test positive, and we would recommend that everyone have COVID-19 test kits at home ready to use. They should be covered by your insurance plan, at least in the state of Massachusetts, but have them know how to use them, follow the instructions carefully. So get tested as soon as your symptoms start. And then if you do test positive, contact your healthcare provider right away. And we recommend not delaying so that you should start treatment as early as possible. Are there medications that or treatments that immunocompromised patients can take? And the answer is yes. So the National Institutes of Health guidelines suggest that we can use either intravenous remdesivir or Paxlovid pills. Paxlovid often can't be given because of drug interactions, so that remains a challenge. We always have to look at the drugs people are on and think if it's safe to give it. It can be quite challenging to organize intravenous remdesivir because it requires outpatient infusion clinic, but that's actually gotten streamlined and is better than before. Remdesivir in some settings can be quite prohibitive, and I know that many rural hospitals and others may not carry remdesivir because of the significant cost and lack of ability to cover that cost. Molnupiravir is another type of pill that is generally reserved as a third choice due to decreased efficacy in multiple clinical trials, but nonetheless sometimes is the best or most available option. Unfortunately, we had monoclonal antibodies, varying monoclonal antibodies, so truvimab, biptolizumab, but none of those are currently effective for treatment. Those were kind of glory days where we could give what I called a one and done monoclonal antibody that would often last for at least several weeks. We saw great clinical efficacy. We don't have any of those just now. We may have more in the future. When people are admitted to hospital, which fortunately is increasingly rare, we have the lowest number of people with COVID-19 at Mass General that I have seen in, I think, since the beginning of the pandemic. That's great news. And we often use steroids with remdesivir intravenously. And some of the monoclonal antibodies that we give are not directly against COVID, but they're to modulate the immune system, because part of the problem with COVID has been the immune system's response to COVID. And one thing that's challenging is for people who are already on drugs that alter the immune system, what type of monoclonal antibody and or steroids should we be given? And that is a very carefully thought through decision on an individual patient basis. So just some hot updates on treatment. This came out last night in an MGB email. So the FDA is expected to formally approve Paxlovid soon. There's a committee that voted strongly in favor of approving it. Adolescent use may remain under emergency use authorization. The FDA concluded that evidence does not support that Paxlovid causes COVID rebound. There's been a lot of discussion about whether Paxlovid results in rebound. And actually, when they looked at it compared with people that didn't have any treatment, it's actually the same. So we in infectious disease have always known that patients with viruses do get, symptoms that kind of come and go. This whole rebound issue has actually caused a lot of damage. There are doctors that won't give Paxlovid because of the risk of rebound, which does not make a lot of sense to me. But so they actually looked, and the rates of rebound are the same with or without Paxlovid. So we do actually strongly recommend that people get it when needed. The FDA review concluded that drug interactions are the principal risk with Paxlovid and sometimes can cause even deadly events. So that's something that needs to be done very, very carefully. And fortunately, remdesivir infusions are much more available than before, in part due to decreased demand. And so we have the capacity to do infusions quite easily, at least 6 days a week through the MGB system, which, as you know, is far and wide these days. So a lot of people contact their doctor and are actually told either they don't qualify or they're not prescribed or whatever. There's some roadblock. I think that for all of you attending this meeting, if you are on medications that alter your immune system or suppress your immune system, you should be getting treatment. If a first doctor says no, I would probably go on and try to pursue additional treatment from other providers who may be available to you. Or I would emphasize to the first provider that you are immune suppressed and at high risk, and you really need the treatment. Unfortunately, Paxlovid can't always be given because of the drug interaction situation, so we often do have to go with either remdesivir intravenous or molnupiravir. So should I go to a local hospital or should I travel to Mass General? I live more than an hour away from MGH. I do think that many of the local hospitals can do quite a good job with this. Our emergency room is chronically beyond capacity. I don't think we've been not beyond capacity in eon. So it is long waits and there can be kind of delays in the emergency room. I do think that many of the larger community hospitals do have good treatment. And so I think that it is reasonable to consider starting there. It's also good to think about a plan basically at this point in the pandemic, if you haven't had COVID yet, I think sooner or later, we're all going to get it. No matter how hard you try, it sneaks its way in. And so I think it's worthwhile talking to your providers about what the plan would be. I can tell you that I can easily look at someone's medication list and say, if you get COVID, we can't give you Paxlovid. We would refer you for intravenous remdesivir, or if that's not available, molnupiravir. So then when I see people in clinic, people know what the plan's pretty much going to be when the day comes, because it's no longer if, it's when. I think we really need to embrace that. How are COVID positive patients doing without the monoclonal antibodies that we previously had? There's actually really good news so we have the most information across Mass General Brigham, MGB, for organ transplant patients. And of the transplant patients, which is a similar, slightly different, but similar population, of that population, of all of them who are generally well vaccinated and who get treatment, only 2% go on to have severe disease. So that is great news. Like we are seeing, I can tell you, things are so much better now than they were over a year ago with Omicron. As one of the major care providers for these patients, we rarely have very sick patients with COVID-19 who are immunocompromised these days, in part because people are so well vaccinated. So things are much better than they were. 2% is still too high for me. Like that's still too high, but it is so much better than it was. How can we best protect ourselves? You all know about masking, you're all wearing one, wonderful. Vaccines, I'll talk more about. Hand hygiene, it's still the same rules. What about boosters? So the current recommendation is that everybody, if you haven't had COVID in the past 3 months, and that you should all have had a bivalent booster. Okay. Sometimes the timing of the bivalent booster is something to discuss with your doctor or clinician who is prescribing your immunosuppressive medication, like especially rituximab and many other agents. But you might want to talk about the timing. For things like rituximab, we usually recommend that a booster be given about a month before the next dose of rituximab. And if a dose, sometimes the dose was, all kinds of things happen. Sometimes the dose is given just after rituximab was given, or it was given in the setting of, you didn't know that 3 days later you'd have a flare and would get high dose steroids or something like that. We actually are allowed to repeat. There's a clause in the guidance that we are allowed to repeat a dose of vaccine if it was given in the setting of intense immune suppression. I actually argued for that clause. I said we need clinical flexibility. So that was written pretty much for all of us in the room. And we don't have a recommendation for an additional bivalent booster so far, but keep your eyes peeled, because I think as we move away from the emergency situation, and as of May, we will no longer be in an emergency pandemic situation, at least on a political level or whatever, at least in Washington. Yeah. So as we move away from that, the FDA is likely to make a lot of the vaccines and medications no longer emergency use authorization, which has been very restrictive as far as our capacity to do things. And as they move more towards regular labeling, we'll be able to have flexibility. And we believe that when we have flexibility for the vaccines, as someone who sits, the FDA approves vaccines and we make recommendations. So as someone who sits on a vaccine committee, we believe that once they make things more flexible as far as licensing, we will be able to be more flexible with our recommendations. I don't have any information, definitive information, but I would keep your eyes peeled, and there may be a recommendation in the next month or two that immunocompromised patients get another bivalent booster. So far, we can't do that, and it would be a violation of the emergency use authorization unless you were given a dose of vaccine in the setting of intense immune suppression. And we really do recommend that people get the bivalent booster. I am currently working in the hospital, and the majority of immunocompromised patients I see have not had a bivalent booster. I don't know what they're waiting for. There's always, they think they had enough. I don't know what, it's chaos out there. So everybody should do their part and be vaccinated. If you have questions about timing, talk with your clinician. Here's a graph that just came out. This is through 2 days ago, as far as in the state of Massachusetts, who's had booster coverage. And you can see that even of people at highest risk for severe disease, those over the age of 75, only 23% have had a booster. This is like if all of a sudden everybody just took off their seatbelts in their car, which people get really indignant when I say, do you wear a seatbelt in the car? And they're like, of course I do. Why haven't you had your bivalent booster? Same, right? Like we're all like, basically, it's like we're drinking and driving and not wearing seatbelts from my perspective. Evusheld. Evusheld was this monoclonal antibody. It was a combination of 2 different antibodies that was quite protective against prior strains. It's no longer protective. It's been removed from the market by the FDA due to lack of efficacy. There are some new versions that are under investigation. It will probably be at least 6 months until they're available. There are some clinical trials that are enrolling people, and they are especially interested in finding immunocompromised patients. We're not sure if we will be a study site at Mass General. I believe Brigham will. You may be able to enroll in a clinical trial if you want early access. You would get either probably the monoclonal antibody or what we call placebo, so nothing. If they haven't had a COVID-19 booster, should we assume that people have no protection? I wouldn't say no protection, just low protection. So it's like basically just keeping your levels up, boosting, fading. If you do have clinical disease, we say that you don't need another vaccine for at least 3 months afterwards, because that has served as a booster. So one of the big things is checking antibodies, and everybody wants their antibodies levels checked and blah, blah, blah. And it's not recommended by the CDC. It's not recommended by Mass General Brigham. It's not recommended by NIH. And what really happens is it gives people, and I don't like antibody testing. So far, we don't know what antibody level conveys protection. Also, people may have a positive antibody level, but no, there are 2 different arms of the immune system. One is antibody and one is what we call cellular. And some people, we've done research at Mass General, some people are positive by one, but not by the other. So I think if they have positive antibody, but no cellular immunity, which we can't measure in clinic, they might have a false sense of protection, take off the mask. And I always say, go to the discotheque, which I think ages me because apparently the young guys don't know what a discotheque is, but you know what I mean, the discotheque, right? So it gives people a false sense of security. We aren't recommending this. It doesn't change what we do. So that's why if you're, if people are telling you, oh, you should get your antibodies checked and your doctor doesn't know what they're doing and blah, 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 you should do this. Yeah, it's a lot of noise. And I think it gives either false sense of security. The other thing is when it's zero, it doesn't mean that you don't have cellular immunity. It just means your antibody titers are low, but it shouldn't really change practice because realistically, either way, you're at risk for infection. So either way, like you have to wear the mask. Like nothing that we're going to do is going to promise you that you can go to the discotheque. So it's really unfortunate. And we do understand this. We've talked at the FDA level, the CDC level. We would love to be able to tell you like, yeah, you're okay. You're good, at least for the next 3 months. Like we would love that. So far, we don't have that. What should my family and close friends do to protect themselves and me? We talk about cocooning or protecting cocooning the immunocompromised patient by surrounding them by vaccinated people who are less likely to bring disease into the home or into that setting. So if people ask you what can they do, they can get vaccinated. Is it safe to remove my mask only while eating when indoors? So it's hard. It's been a long 3 years, right? So whenever you take your mask off indoors, there is risk. I think it's about decreasing risk. So I met with a patient this week and we talked about how when he gets on an airplane, he wears his mask the whole time on an airplane. Okay. When he goes to a restaurant, he wears his mask the whole time he's walking through the restaurant, kind of walking in, all that shuffle of walking through. And then when he sits down, he reads the menu, he orders, but when the food comes, he takes off his mask. So it's not zero risk, but he has greatly reduced the risk, especially when he's walking past all the people. And, I always say COVID is a disease of breathing other people's air. So usually when you're sitting, like they're sitting over there, you're over there. If they take off their masks and they have COVID, it's unlikely that you guys over here are going to get COVID from them. But if you're unmasked and like walking all through, that's how you get COVID, by breathing other people's air predominantly. So I am immunocompromised, how limited I should be with outdoor activities. So in general, we love outdoor activities. If it's really crowded, like I know that I've been involved in cases where there was transmission at like a Red Sox game or other tightly packed situations. I do think that outdoor activities are greatly reduced risk. I'm so happy spring is coming. We can all be outdoors. It's a lot safer. But if it's a tightly crowded situation, a concert, something like that, you should still be wearing a mask. What about travel medicine? So I do a lot of travel medicine, and I love this part of my job because it means people are healthy and strong and want to travel and go on trips and visit friends and relatives and all kinds of things. So what about air travel? So I do think that we are in an era that we know so much about masking that what I recommend doing is I always say, I'm a mom, so eat and drink a ton at home. So you're not hungry, you're not thirsty. Like at home, eat and drink, like really stock up. Before you get to the airport, put on your mask. N95 is best, KN94, a really good mask, not just the surgical mask, but a really good mask. Wear it the whole time you're in the airport. Wear it the whole time on the airplane, the whole time when you're in the destination airport, and then whenever you're in crowded places when you're traveling. But I do think people can travel now. I will say that the vast majority of the other people in the airplane are not masked, but you can mask, do hand hygiene, all of that. And I think that you can really successfully take care of yourself and overall decrease the risk of exposure. If you were on the plane, if it's a really long plane, I have a lot of people flying to Europe and elsewhere. One thing, there are different kinds, like you have the kind of mask that wraps around your head, the kind around your ears. You can alternate, it's hard to wear those for hours. So I often will say, like, go to the bathroom, only because it's a closed space, right? And then just quickly take off mask A and put on mask B. So that way, if you're getting like that ear pain or whatever it is, this is actually what I do. I think it works pretty well. But so just change your mask up, but really try to, and when they offer you the free drink and the, little bag of pretzels, just pass, because you've had enough to eat and drink at home. There's still a lot of COVID out there in the world. There's still a lot of deaths going on. It is much better than it ever was. People ask me about travel to all kinds of places, but realistically, the US is still one of the hot spots of internationally. So I do think it's reasonable to consider travel. Right now, there's a hot spot in, my son arrived in Vienna yesterday, and that's right where the hot spot is internationally in Austria. And then New Zealand's another hot spot, but don't worry, that'll probably go away. They usually do a good job with things. But do think about, this is one of those life balances, and it's about personal risk and accepting, risk versus benefit. It's been a long 3 years, and at some point you may wish to travel. If you really want to look up an individual country as far as risk, there's a great website called, you can Google CDC destinations and the country, and you can get a whole raft of information about various outbreaks and all kinds of things about an individual destination. But as I mentioned, masking, make sure your vaccines are up to date, have a good plan in place if you get sick when you're traveling. So that's something to really think about. I do meet with a lot of people in my clinic who are traveling to high-risk destinations. So the high risk is outside of Europe, Canada, or Australia. But it's good to have a plan in place. When will immunocompromised patients be able to live a normal life again? These were questions submitted for a transplant meeting. So I think we can get closer to normal through safety. We've learned a lot. In the beginning, we weren't even sure if we should mask. It's chaotic in the beginning. We now know how to take good care of ourselves. And I think most of our loved ones, our friends, our families, our close people around us know how to support us and know that immunocompromised patients should be having outdoor meals, going on picnics, going for walks outdoors, that there are just some things that can't really be done as safely as others. So I think it's about eking our way towards normalcy, but using the safety measures we've learned about over the years. I don't think life will be normal for any of us for quite some time to come. As a doctor, I also don't live a normal life because I may have to be out of work for up to 2 weeks if I get sick, which is a drag. So I definitely share this with you. Okay, this isn't about COVID, but everybody always asks about gardening. And for people who are immunocompromised, they are at risk for various infections. If you are gardening this spring and summer, wear gloves, good gloves, wear long pants so you don't get cuts on your shins, and then mask up, especially if you're doing tilling the soil or really turning things over, because you can get mold infections, you can get other kind of bizarre infections. So just throw on a mask if you're out in the garden and then protect yourself. Gloves, pants, etc. I know I'm only supposed to talk about COVID, but I just couldn't help myself and I had to talk about what else do I wish you knew about. Make sure you keep your routine vaccines up to date. Talk with your clinicians about timing of vaccines, but anyone with vasculitis should have up-to-date pneumonia vaccines, 2 doses of the shingles vaccine. This is a dead vaccine, safe, well-tolerated, recommended for anyone whose immune system is suppressed over the age of 18. Influenza vaccines, tetanus boosters, COVID-19 vaccines, hepatitis A, hepatitis B, when indicated, and then monkeypox vaccines for people who are mpox vaccines for people who need that. Mumps, measles, rubella, and chickenpox vaccines are not recommended for people who are on medications that suppress the immune system. Again, the new shingles vaccine is fine. The old shingles vaccine was not fine. It's off the market in the US. You can't get it if you wanted it. And so if traveling abroad, think about coming to travel clinic and just make sure that the provider you see, if you go to a travel medicine clinic, is aware that you are immunocompromised. Don't drink untreated water. Also don't either from wells, lakes, or the ocean, and don't necessarily swim in untreated fresh water, and salt water has some risk. Stay up to date on your dental work, see a dermatologist regularly. Those things will keep you out of a lot of trouble. And I am happy to have questions. Everybody always has a lot of COVID questions.
Thank you for all this good information. One question I have, you spoke about someone going to a restaurant and keeping their mask on until they were just about ready to eat. So it raises, I've read lots of seemingly conflicting information about how close contact needs to be, or for how long, of breathing in other people's air who may have COVID or other infectious diseases.
And we know that people who are immunocompromised are at risk for a lower exposure, like something that might not affect someone else may be more likely to infect someone who is on drugs that suppress the immune system. So by no means am I saying it's totally safe to do this. I'm saying it decreases your risk if you mask the whole time and then really just take the mask off for, the kind of relatively short time that you're eating. You can also do things like make sure you're going like either early or late when the restaurant's less crowded, and also go to a restaurant that's just not that crowded. Like I don't go to crowded restaurants anymore, just go somewhere where it's pretty, like the fewer the people, the less other people's air you're breathing, and then the overall lower risk. So I do think you can also just, if you want no risk, takeout, right? Takeout's great. But if you're kind of like, I kind of really want to do this and I'm willing to have some risk, and I understand that there's good treatment now, I've had a lot of vaccines, I'm feeling better than before. That doesn't mean like take off the mask and just run around. I think wear the mask most of the time, like 90% of the time, and then take off the mask just to eat, put the mask back on, and then dessert comes, mask off. And that's kind of like greatly lowering your overall risk. I think especially like walking through the restaurant, depending on the size and all of that. Hope that makes sense. So I'm not saying it's perfectly safe. I'm just like, it's about decreasing our risk, because that's where we are in this pandemic, right? It's also been 3 years, and for social and emotional reasons, it's been a really, really long, hard time, and we really appreciate that. Yes.
My name is Glenn, and please feel free to dodge this question if it's a little bit too gnarly. I have a social event coming up next year. It's going to be a wedding where there is likely to be a fairly large number of people who may be unvaccinated. My guess would be probably not a good risk management decision to be amongst knowing unvaccinated people. Does that make any kind of medical or scientific sense?
Yes, weddings are rough. There's a lot of outbreaks associated with weddings. So for me, it depends on the time of the year, whether it's an indoor wedding or an outdoor wedding. I have this whole, it's about being clever, right? So I have this whole, like one patient wanted to go to an outdoor wedding, but he thought it would be crowded in the tent. So I said, well, can you attend the wedding, but like kind of outside the tent, wearing your mask outside the tent? And then can you like position yourself? He wanted to go to the ceremony, and he thought he could watch outside the tent wearing a mask, sort of a little distanced, because he had the same situation. A lot of America has decided to not get vaccines or not be up to, the majority of Americans are not up to date on their vaccines. And being vaccinated isn't 100%, but certainly does decrease the risk. So we all have those family members and friends. Yes, this is where America is in the pandemic, unfortunately. I will say, if people want shorter wait times in the emergency room, it would be helpful if people would get a lot more vaccines. And then like if you break your leg, you'll have a shorter wait in the emergency room. Just saying that if you want to debulk the emergency rooms, that would actually help. So I would be, if I were immunocompromised, I'd be reluctant to go to a wedding without a mask, but I think you can wear a mask. And I do understand that sometimes the people that aren't vaccinated are also anti-mask, which can be challenging. You could choose to go to part of the wedding, the ceremony, whatever part that you think you might be able to get through. But I would be cautious. If you can be outdoors at all, that's great. If it's like a winter wedding or whatever, if that's not possible. And yeah, sometimes we are missing those major milestone events, which is tragic. I've dealt with that situation a lot. It's also devastating when people do get sick from it. But we're all making those decisions. I recently decided that I was going to go to a family event because it had just been too long. And so I kind of, did it. My risk is overall relatively low. I'm well vaccinated. I did it. I was nervous. We got through, but these are higher risk situations. When you talk about breathing other people's air, weddings, funerals, those events are tough. But if you can mask the whole time, it's pretty low risk. But it is hard socially to mask, like yelling through an N95 when there's like music blaring and stuff. I get it. But maybe you can take your friends outside. Like you could be like, I'm kind of doing this wedding in the hallway. I don't know. Be creative. Don't breathe other people's air.
Hi, I was just wondering, was it really interesting to see the Paxlovid and rebound COVID data? I was wondering if it was more likely for patients who are immunosuppressed or on biologics to have rebound COVID with Paxlovid, or was it just across the board pretty standard?
They didn't look carefully, but that's not been my experience. And I feel so strongly that we should definitely be treating anyone who's immunosuppressed with either remdesivir, Paxlovid, or molnupiravir. We should be treating everybody, period. That rebound thing was killing me. It's like, it would be like, I wasn't going to drive my car here today in case I got an offender bender, so I'm just going to stay home. Like, that doesn't make any sense, right? Like it really drove us crazy, and it was kind of so detrimental. And I saw so many patients that were harmed by the concern about rebound, right? Like I drove my car here. If you should do what's right and then deal with things later. Sometimes we give immunocompromised patients longer courses of treatment, definitely not standard. The vast majority do fine. I can't tell you how much better people are doing now compared to before. So yeah, I'm not worried about rebound. I had COVID and some of the rebound stuff is not even COVID. It's actually like post-viral, post-nasal drip and all of those things that still exist out there. Great. I'll stay in the back of the room for a little bit and then I have to go back to the hospital and work, but nice to see you all.
All right. Thank you, Dr. Cotton. So we're going to take about a 10-minute break now so we can regroup about 20 minutes after. And then we'll come back for 2 talks and then we'll have lunch during the next break. And then we'll have 2 talks from the Vasculitis Foundation. So thanks so much. And we'll regroup in about 10 minutes or so.